Hello, everyone. This is Jeanne Poole. I'm the editor-in-chief of the Heart Rhythm O2 Journal, and this is the June 2025 podcast. Just like last month, we have a packed lineup of papers. I'll try to summarize them very briefly, either through the abstract or the author's key findings. We start out with a paper titled An Alternative Method for Phrenic Nerve Monitoring During Cryoballoon Procedures by Dr. Alessio Marinelli and colleagues. The background for this study is that cryoballoon ablation has been associated consistently with the risk of phrenic nerve damage. The authors note that abdominal palpation and other strategies, such as the diaphragmatic compound motor action potential, or CMAP, have been shown to be effective and reliable methods for preventing this complication. The author's objective is to evaluate the diagnostic performance of a new surface CMAP electrodes position. They study a total of 150 patients with a total of 438 cryoballoon applications performed on the right pulmonary veins. The authors find that the CMAP with regard to nerve damage had a sensitivity of 38% and a specificity of 76%, with a negative predictive value of 89% and positive predictive value of 19%. The need map showed sensitivity of 61%, specificity 86%, negative predictive value 93%, and positive predictive value of 40%. The authors therefore conclude that the need map signal for phrenic nerve monitoring during cryoballoon ablation seems to be a reliable method. It shows good sensitivity and specificity and can help clinicians in preventing phrenic nerve damage. The title of the next paper is Association Between Quality of Life and Redo Procedures After Pulmonary Vein Isolation in Atrial Fibrillation Patients, Data from the Netherlands Heart Registration. This study is first authored by Dr. Mylene van de Kar and colleagues. The background of this study, that the authors note, is that AF significantly impacts quality of life, necessitating effective therapeutic interventions such as catheter ablation with PVI, and that although PVI's success is often measured by freedom from all arrhythmias, clinical practice emphasizes symptom freedom and patient comfort as captured by QOL tools such as the AFFECT questionnaire. The objective of their study was to investigate the association between baseline QOL, changes in QOL, and redo PVI, aiming to align patient-centered outcomes with clinical decision-making. The patient population is comprised of 3,336 patients undergoing first-time PVI between 2018 and 2021 from Dutch heart centers. Patients who had baseline and one-year follow-up QOL scores were categorized into quartiles based upon pre-PVI AFFECT scores and redo PVI rates assessed within 1 year. 16% of the patients had redo PVI. The authors find that the median AFFECT scores improved significantly from 53.9 to 71.3 in redo patients and from 57.4 to 88 in the other patients. Higher baseline QOL scores correlated with lower redo rates, with odds ratios for redo PVI of 0.93, 0.74, and 0.62 compared with follow-up. Redo PVI rates varied significantly between heart centers, which the authors state reflects practice variations. The authors then go on to conclude that lower baseline QOL is associated with a higher likelihood of redo PVI, and that emphasizes the role of patient-reported outcomes in AF management. The authors suggest that integrating QOL assessments into routine practice can support individualized care and create risk stratification and contribute to standardizing clinical decision-making. Next up is a paper titled Outcomes in Diabetic versus Non-Diabetic Patients Requiring Cardiac Resynchronization Therapy for Heart Failure, a meta-analysis by Dr. Aman Goyal and colleagues. The authors offer as background that heart failure affects millions globally, causing severe symptoms and poor prognosis, and that CRT therapy has been shown to improve heart function and quality of life in heart failure patients with electrical dyssynchrony, but its effectiveness in diabetic patients remains unclear due to the complexities associated with diabetes. The objective, therefore, of this author's study is to evaluate the impact of diabetes on CRT by comparing outcomes between diabetic and non-diabetic patients using a meta-analysis statistical approach. The authors perform a comprehensive literature search, identifying studies in CRT in heart failure patients both with and without diabetes mellitus. Pooled risk ratios and mean differences were calculated using a random effects model with 95% confidence intervals and statistical significance set at p less than 0.05. The meta-analysis includes 13 observational studies involving 20,073 patients, and the results showed that diabetic patients had a significantly increased risk of all-cause mortality, cardiovascular death, compared with non-diabetic patients. But no statistically significant difference was observed between the groups for the risk of stroke, myocardial infarction, changes in left ventricular ejection fraction, and left ventricular and systolic or diastolic volumes. The authors conclude that these findings suggest that diabetic patients undergoing CRT face a high risk of all-cause and cardiovascular mortality. The increased mortality risk they suggest highlights the need for tailored treatment strategies, emphasizing the judicious use of CRT in diabetic patients. The title of the next paper is Pre-Procedural Neutrophil to Lymphocyte Ratio, a novel predictor of permanent pacemaker implantation in self-expandable versus balloon expandable valve cohorts following transcatheter aortic valve implantation by Dr. Haitham, Khadija, and colleagues. The background of this study is that transcatheter aortic valve implantation, or TAVI, is the preferred treatment for severe aortic stenosis. The study here examines the neutrophil lymphocyte ratio as a predictor of permanent pacemaker implantation outcomes, comparing the two types of TAVI valves. This is a retrospective cohort study conducted at the Kaplan Medical Center at the University of Jerusalem. Data are collected on baseline characteristics, lab results, and clinical outcomes. The authors find that in the self-expandable valve cohort, 59 of 199 patients, or 29.6%, required a permanent pacemaker implant, compared to 15 of 106 patients who had a balloon expandable valve implanted, and that was 14.2% in that cohort. The receiver operating characteristic, or ROC curve, for the self-expanding valve showed an area under the curve of 0.70, indicating predictive ability of the neutrophil lymphocyte ratio for TAVI PPI outcomes. The balloon expanding valve cohort had a lower AUC of 0.40. In the self-expanding valve model, significant predictors included the neutrophil lymphocyte ratio and total protein levels. In the balloon expanding valve model, the QTc interval was significant. The authors conclude that the neutrophil lymphocyte ratio significantly predicts permanent pacemaker implantation after TAVI, especially for self-expanding valves, but less so for the balloon expanding valves. Next up is a paper titled Current Practices in Managing Patients with Cardiac Implantable Electronic Devices, Results of an International Survey by Dr. James Allred and colleagues. As way of background, the authors state that managing patients with CIEDs is increasingly complicated with expanding populations and evolving technologies. And while the 2023 Heart Rhythm, European Heart Rhythm, FHRS, and LARS consensus on management of remote device clinics provides recommendations, the adoption of these practices in real-world practice is unknown. This survey of device clinic staff characterizes the adoption and variability of CIED follow-up practices. A Delphi panel composed of U.S. and European Union clinical experts guided the research objectives, structure, and content of the survey. Once consensus was reached, the online survey, Qualtrics, was deployed in partnership with HRS through email, social media posts, and at the HRX conference. An available case analysis was performed to handle missing data. A total of 471 responses were collected from 44 countries, including 310 in the United States, 88 in Europe, and 73 in other regions. Broad representation was achieved with respect to staff role, years of experience, and clinic ownership. 71% of the respondents reported being aware of the 2023 consensus statement, while the majority, 77 to 83%, depending upon device type, reported using hybrid in-person and remote management for patients with therapeutic CIEDs. 89 to 91% reported scheduling routine office visits at least once per year, depending on device type, respectively. Only 50% of the respondents reported a hybrid approach for insertable cardiac monitor patients, with 35% reporting remote-only follow-up. The authors conclude that variable adoption was found for many practices recommended in the 2023 consensus document, and that future research should focus on optimal implementation of recommended practices. The title of the next paper is Evaluation of Cardiac Energetics in Left Bundle Branch Area Pacing Using Non-Invasive Pressure Volume Loops. This paper is written by Dr. Jeanne E. and colleagues. As way of background, the conduction system pacing, particularly the left bundle branch area pacing, has emerged as the preferred strategy for bradyarrhythmias and cardiac resynchronization therapy because of its clinical benefits. However, the differences in the impact of LBBAP versus right ventricular pacing on cardiac energetics remains unclear. The author's purpose of the study was to compare the effects of LBBAP and RBP on cardiac energetics using a novel, non-invasive pressure volume loop algorithm derived from cardiac magnetic resonance. The authors included patients who underwent permanent pacemaker implantation with either approach, LBBAP or RBP, between January 2021 and October of 2024, followed by CMR imaging. Non-invasive PV loops were calculated using volumes that were derived from the CMR and a time-varying elastance model. The parameters obtained from the PV loop analysis were compared between the LBBAP and the RBP groups. Sensitivity analyses were performed by varying the left ventricular end diastolic pressure between 3 and 40 millimeters of mercury and excluding anodal pacing cases. The number of patients analyzed was 15. There were 7 in the LBBAP group and 8 in the RBP group. The end-systolic PV relationship was significantly higher in the LBBAP group compared to the RBP group. The potential energy and PV area were significantly lower in the LBBAP group, whereas the ventricular efficiency was significantly higher. The authors conclude that LBBAP reduces myocardial energy consumption and improves ventricular efficacy compared with right ventricular pacing, suggesting its advantages in pacing-associated cardiac energetics. The title of the next paper is Pain After Subcutaneous Implantable Cardioverter Defibrillator Implantation, a Secondary Analysis of the Praetorian DFT Trial by Dr. Julian de Velde and colleagues. The authors offer as way of background that the SICD overcomes transvenous lead-related complications. Its extrathoracic design results in a generator twice the size of transvenous ICDs. The authors investigated pain after SICD implantation and explored predictors for severe pain. The authors used the Praetorian DFT trial, which included 965 patients undergoing SICD implantation in 37 centers across Europe, the United States, and Israel. Pain was assessed using the numeric rating scale ranging from no pain to unbearable pain. The numeric rating scale was measured before implantation and 1 to 4 hours, 5 to 7 hours, 1 day, and 1 to 4 months after implantation. 2 questions about implantation experience were asked at follow-up. Logistic regression analysis was used to identify predictors. Implanting physicians were asked what their expectations were on the pain experience. The Praetorian DFT trial enrolled 24% females. The mean age of the population was 54, and 45% had an ischemic cardiomyopathy. The median NRS within 1 day after implantation was 4. Pain was most frequently experienced at the pocket. 29% of the patients reported severe pain, that was an NRS equal to or greater than 7, within 1 day after implant. Predictors for severe pain were female sex, procedure duration, and severe pain at baseline. Additionally, female sex was a predictor for disappointment in pain perception during and after implantation. Physician anticipated NRS and location corresponded with reported pain. The females were expected to have more pain by 4 of 24 physicians. The authors conclude that in the periods surrounding SICD implantation, attention should be paid to analgesia and expectation management in patients with longer procedure duration, severe pre-existing pain, and especially in female sex. Next up is a paper titled Diagnostic Performance of Single-Lead Electrocardiograms from the Apple Watch and Cart Ring for Cardiac Arrhythmias by Dr. Andre Briosa Egala and colleagues. The background of this study is that wearable devices are widely used for atrial fibrillation detection, Yet most validation studies include only sinus rhythm or AF, likely overestimating diagnostic performance. This study is a multi-center study addressing the performance of automated AF detection and physician interpretation of single-lead electrocardiograms from the Apple Watch and CART ring. Participants underwent simultaneous 12-lead ECG and single-lead ECGs from the Apple Watch and CART ring. 2 cardiologists independently adjudicated all ECGs. Apple Watch and CART ring recordings were classified as AF, not AF, or unclassified. Diagnostic performance for automated AF detection was evaluated as worst case, all single-lead ECGs, and lenient, excluding unclassified single-lead ECG, scenarios. Physician interpretation of single-lead ECGs was also compared to 12-lead ECGs. 483 patients were included and represented a total of 2,398 ECGs that were analyzed. Inter-observer variability was excellent, with a Cohen's kappa for the Apple Watch of 0.85 and for the CART ring of 0.84. In the worst-case analysis, CART ring outperformed Apple Watch with a sensitivity of 84.6% compared to 69.1%, specificity 89.9%, versus 72.6%. The Apple Watch had more unclassified single-lead ECGs, 20.1%, than CART ring at 1.9%. The lenient analysis showed an improvement in sensitivity, CART ring 84.8%, Apple Watch 86.4%, and specificity, CART ring 95.2%, and Apple Watch 91.7%. Physician interpretation improved diagnostic performance for AF and sinus rhythm, but remained limited for other arrhythmias. The authors conclude that the Apple Watch missed approximately 1 in 3 episodes of AF, and a high number of unclassified single-lead ECGs. The CART ring demonstrated superior performance. Physician interpretation significantly improved AF diagnosis, but remained unreliable for other arrhythmias, emphasizing the need for cautious integration of wearable ECGs into clinical practice. The title of the next paper is Association Between Ultra-Short-Term Heart Rate Variability of Time Fluctuation in Atrial Fibrillation, Evidence from the MIMIC-4 Study by Dr. Zhouji Tang and authors. The background of this is that ultra-short-term heart rate variability has been found to be associated with atrial fibrillation, but research in this area is limited. Therefore, the objective of this study was to investigate the association between ultra-short heart rate variability metrics and AF, which will be abbreviated as USHRV. The methods include that this is a retrospective cohort study with 48,416 participants from the Medical Information Mart for Intensive Care 4 database. USHRV time domain and frequency domain metrics were also collected. The authors examined the connection between USHRV and AF in electrocardiogram samples collected from 8 o'clock to 1800, 1800 to 8 o'clock, and all day to understand the impact of time on the findings. To address the research objectives, the authors used Cox regression analysis, stratified curve fitting, threshold effect analysis, subgroup analysis, and the assessment of interaction effects. The authors found that during an average follow-up of 1.88 years, 3,611 participants developed atrial fibrillation. USHRV time domain metrics were unstable in a day, and the HR was more significant in those 55 years of age and older, which was a statistically significant interaction. In contrast, the USHRV frequency metrics were more clinically significant and stable. Their hazard ratios for the 8 in the morning to 1800 samples were 0.79 for log ratio of low frequency and high frequency, 0.74 for log low frequency normalized units, and 2.26 for log high frequency normalized units, respectively. The authors conclude that the frequency domain metrics of USHRV exhibit strong stability, surpassing those derived from time domain metrics, and offer improved convenience compared with heart rate variability, and that this makes them particularly notable for their clinical significance. Next up is a paper titled Temporal Trends of Atrial Ventricular Block in Acute Coronary Syndrome Patients from the ACES Registry by Dr. Shirtal and colleagues. The background of this study is that high-degree AV block is a life-threatening complication amongst acute coronary syndrome patients. The purpose of this author study was to investigate temporal trends of the last 2 decades in incidence and prognosis of patients with high-degree AV block amongst patients who presented with ACS. The authors evaluated 18,717 ACS patients from the multi-center ACES, which is the Acute Coronary Syndrome Israeli Survey Registry. Temporal trends were examined in early 2000 to 2010 and late 2013 to 2021 periods. The authors found that overall, a high degree of AV block was diagnosed in 3.5% of the patients in the early period versus 2.33% in the later period. Temporary pacemakers were implanted more frequently in the early versus the late periods also, though the implantation rate of permanent pacemakers seemed to be similar in both periods. Patients with high-degree AV block from the late period experienced lower major adverse cardiovascular events with 30-day mortality of 18.9 versus 29.2% and 1-year mortality of 26.1 versus 36.5%. In multivariable analysis, admission Killip class greater than 2, diabetes mellitus, and late period compared to early period were independent predictors for 1-year mortality. The authors conclude that ACS patients with high-degree AV block experience elevated short and long-term mortality rates overall. However, there has been improvement in the outcomes for this population through the years. The title of the next paper is Cardiac Arrest in the Australian Alps, a 20-year analysis by Dr. Elizabeth Peretz and co-authors. As way of background, the authors state that alpine tourism annually attracts over 100 million visitors globally. Age and cardiovascular comorbidities in alpine tourists are increasing, and rates of out-of-hospital cardiac arrest have been hypothesized to be higher due to exertion and physiologic stress. The authors looked at cases of alpine out-of-hospital cardiac arrest from the years 2002 to 2021. These were identified from the statewide Victorian Ambulance Cardiac Arrest Registry. Alpine and non-alpine out-of-hospital cardiac arrest characteristics were compared. Causes of alpine out-of-hospital cardiac arrest were obtained from hospital discharge diagnoses in the National Coronary Information System. The authors found that approximately 15.3 million alpine visits were recorded over the time period during which 13 alpine out-of-hospital cardiac arrests occurred, which is 0.04% of the 32,179 out-of-hospital cardiac arrests, or 0.8 arrests per million alpine visits. Compared with non-alpine out-of-hospital cardiac arrests in a public setting, the alpine out-of-hospital cardiac arrest patients were younger with a mean age of 52 versus 63 years with higher rates of bystander defibrillation, which was 54.5% versus 13.5%. Survival to hospital discharge did not significantly differ between alpine, 38.5%, and non-alpine out-of-hospital cardiac arrest patients. Ischemic heart disease was the commonest identified cause of alpine out-of-hospital cardiac arrest in both survivors and non-survivors. The authors conclude that alpine out-of-hospital cardiac arrest is very rare in Australia, accounting for only 1 in 5,000 out-of-hospital cardiac arrests and fewer than 1 in a million ski field visitors. Despite remoteness and access challenges, alpine out-of-hospital cardiac arrest survival is high, driven by prognostically favorable arrest-related factors and coordinated local systems of care prioritizing early bystander intervention. Next up is a paper titled In-Hospital and Long-Term Outcomes in Spontaneous Coronary Artery Dissection with Concurrent Cardiac Arrest by Dr. Omar Bakal and colleagues. As way of background, the authors state that our understanding of factors predisposing patients with spontaneous coronary artery dissection, or SCAD, to worse outcomes such as concurrent sudden cardiac arrest and secondary prevention of sudden cardiac death in those patients is limited. The authors conducted the largest systematic review of studies assessing clinical outcomes in SCAD patients with concurrent cardiac arrest. The study was performed according to Preferred Reporting Items for Systemic Reviews and Meta-Analyses, or PRISMA guidelines. PubMed, Cochrane, and Scopus were searched using relevant search terms, including spontaneous coronary artery dissection, ventricular tachycardia, ventricular fibrillation, sudden cardiac death, and cardiac arrest. The search was conducted from database inception to January of 2025. The authors found that out of 269 studies that underwent screening, 10 were included, which represented 3,978 patients. In hospital mortality, post-discharge mortality, recurrent myocardial infarction and recurrent SCAD occurred in 20%, 3%, 12%, and 9% of patients with SCAD and cardiac arrest, respectively. When compared with patients with SCAD without cardiac arrest, patients with SCAD and cardiac arrest were at significantly higher risk of in-hospital mortality with a risk ratio of 6.7. Post-discharge mortality with a risk ratio of 5.9, recurrent myocardial infarction with a risk ratio of 3.3, and recurrent SCAD with a risk ratio of 1.9. Out of a pooled 35 implanted cardiac defibrillators and wearable defibrillators, there was only one appropriate and one inappropriate defibrillator discharge recorded over the follow-up period. The authors conclude that SCAD with concurrent cardiac arrest is associated with worse in-hospital long-term outcomes, although long-term rates of administered defibrillator therapies was low, supporting a conservative approach. The title of the next paper is Automatic Measurement of Short-Term Variability of Repolarization Captures Modulation by Pacing on Human Electrograms by Drs. Jeanne E and colleagues. Background in this study is that short-term variability of repolarization, or STV, increases prior to ventricular arrhythmias in both humans and animal models, making it a promising tool for real-time arrhythmic risk monitoring. The objective of this study was an automatic STV measurement algorithm was developed for intracardiac electrograms to enable integration into cardiac devices. This method previously demonstrated high accuracy in predicting life-threatening ventricular arrhythmias in animal studies. The study compared the performance of the automatic method to the gold standard on electrograms in humans. The electrogram signals were recorded in 14 patients with a dual-chamber ICD during de novo implant, which was 5 patients, or replacement, which was 9 patients. Recordings were obtained in sinus rhythm, with atrial pacing at 80 beats per minute and dual-chamber pacing at 80 beats per minute. STV was determined on the electrogram from the activation recovery interval with the automatic method, which was STV to ARI auto, and with fiducial segment averaging, which is STV ARI PSA. The gold standard STV ARI auto was compared with STV ARI PSA for all pacing modes. The authors found that the STV ARI auto and the STV ARI PSA decreased from 0.90 milliseconds in sinus rhythm to 0.60 milliseconds in atrial pacing at 80 beats per minute and to 0.32 milliseconds in dual chamber pacing at 80 beats per minute, respectively. All p-values were less than 0.05 compared to sinus rhythm. STV ARI auto strongly correlated with STV ARI PSA with a small bias of 0.18 milliseconds and limits of agreement between 0.35 and 0.70 milliseconds. The authors conclude that the novel automatic STV measurement method accurately reflects pacing-induced changes compared to the gold standard. They suggest that future integration of this technique in implantable cardioverter defibrillators could furnish continuous monitoring of arrhythmic risk and initiate preventive strategies. The title of the next paper is Phasic Effects of Cardiac Synchronized Vagus Nerve Stimulation on Spatiotemporal Behavior of the Sinoatrial Node in Swine by Dr. Don Wallach and colleagues. The background of this study is that recent clinical trials of cervical vagus nerve stimulation, or VNS, in heart failure patients failed to demonstrate the expected benefits seen in experimental studies, potentially due to subtherapeutic VNS levels. The timing and burst firing of VNS affects cardiac cycle length prolongation and the shift of the sinoatrial node from a superior to inferior position in mammals, including humans. The objective of this study was to determine if parasympathetic nerves of swine respond in a similar manner to other studies in mammals. 7 pigs were anesthetized using isoflurane for surgical instrumentation before the study. Once completed, the anesthesia was switched to alpha-chlorelose. Cardiac synchronized VNS was performed in bursts for 10 to 20 cardiac cycles. The synchronization of the bursts varied by 100 millisecond increments, followed sensing atrial depolarization. epicardial mapping was performed to characterize the spatiotemporal behavior of the sinoatrial node during VNS in 6 of the 7 animals. The authors found that the average cardiac cycle length before VNS was 517 milliseconds. Altering the synchronized delay of the VNS resulted in cycle length prolongation with a range of 16 plus or minus 6% to 27 plus or minus 18% in pigs, similar to those observed in other mammals. Interestingly, the sinoatrial node shifted inferiorly in only 2 of 6 mapped animals during VNS, regardless of the extent of cycle length prolongation. These shift sites, the superior sinoatrial node and inferior sinoatrial node, alternated between the 2 locations as the cycle length changed. The authors conclude that the temporal behavior of the sinoatrial node during cardiac synchronized VNS in swine is similar to that observed in other mammals, but its spatial behavior is different. Because burst firing of VNS is physiological, future work in swine on its effect on mitigating heart failure should be studied. The next paper is published within our Allied Health Professionals article. The title of the paper is ICD Support Groups, Are They Still Relevant Now? By Sam Sears and colleagues. This is a brief report style, and I'm going to read to you the abstract of this interesting paper. That states that while implantable cardioverter defibrillators save lives in patients at risk for potentially life-threatening arrhythmias, ICD shocks may prompt fear and anxiety and cause potential psychological trauma in patients. Since the beginning of the ICD's broad use, healthcare professionals recognize the unique demands and experiences associated with this therapy. Some clinics responded by initiating patient-focused meetings, broadly referred to as ICD support groups, to address the mental health challenges in these patients. Decades of research have now underscored the importance of ICD patients' psychological and behavioral processes and their associations with adverse health outcomes. ICD patients frequently report disease-specific mental health symptoms, including ICD shock anxiety, poor device acceptance, body image concerns, and decreased physical activity that require unique clinical expertise from professionals to effectively manage. The original impetus for ICD support groups persists, but relatively few ICD support groups remain active. Online offerings may have taken on some of these functions. The authors suggest that ICD support groups remain a strategic intervention to address patient psychological and lifestyle concerns. This paper reviews the value of ICD support groups in the United States, Australia, and Canada, and analyzes the current state and potential value of ICD support groups. The title of the next paper is Cardiac Implantable Electronic Devices in the Setting of Tricuspid Valve Intervention, Risks, Options, Extraction, and Future Perspectives, a state-of-the-art review. This is a review topic paper, and the lead author is Alfonso Liu and colleagues. The abstract for this paper is as follows. Tricuspid regurgitation is associated with increased risk of heart failure and mortality. To address this, tricuspid valve interventions in the form of transcatheter and surgical tricuspid valve procedures have rapidly emerged. Tricuspid valve interventions are associated with significant risk of conduction system disease, necessitating permanent pacemaker implantation. Limited data and current guidelines suggest that transvalvular permanent pacemakers should be avoided to preserve the function of replaced or repaired tricuspid valves. With the rapid increase of transcatheter tricuspid valve and valve replacements in the last decade, the incidence of pre-existing permanent pacemaker lead entrapment poses a clinical challenge in which lead extraction is indicated, particularly in the context of device infection. In this review article, the authors discuss the risks of conduction system disease associated with different tricuspid valve interventions, the options for pacing, defibrillator therapy, and cardiac resynchronization therapy that spare the tricuspid valve, and the management of pre-existing transvalvular pacing leads before tricuspid valve intervention. Furthermore, the authors discuss the future perspectives in this field, including a completely leadless cardiac resynchronization therapy defibrillator system, and propose an algorithm for cardiac implantable electronic device implantation during or after tricuspid valve intervention. The next paper is also a review paper. The title is Veterans Health Administration National Cardiac Device Surveillance Program. Structured, Centralized Remote Monitoring for Cardiovascular Implantable Electronic Devices to Improve Quality of Care by Dr. Sangha Dhruva and colleagues. The abstract is as follows. Remote monitoring is central to care of patients with cardiovascular implantable electronic devices. However, because remote monitoring care presents a large and increasing clinician workload, solutions are needed to increase care efficiency. The Veterans Health Administration National Cardiac Device Surveillance Program is a response to this need by centralizing remote monitoring processes, reviewing all remote monitoring transmissions, identifying patients affected by recalls, and providing guidance on clinical response for 122 Veterans Administration hospital CIED clinics across the United States and Puerto Rico. This surveillance program promotes participation and adherence in remote monitoring, ensuring evidence-based care. The centralized infrastructure also positions the surveillance program to evaluate and implement quality improvement interventions, ultimately enhancing clinical care for patients with CIEDs. This article describes and reflects on this infrastructure and provides specific recommendations about how high-quality remote monitoring care can be provided in other healthcare systems. The next paper is a research letter. The title is Activated Clotting Time for Anticoagulation Management During Catheter Ablation of Left Atrial Arrhythmias, Comparison of Point-of-Care Devices in Clinical Routine, by first author Diana Foucault and colleagues. The key findings of this brief report include, first, that different widely used point-of-care devices for anticoagulation management show a wide range of activated clotting time values, especially at high values greater than 300 seconds, targeted during catheter ablation of left atrial arrhythmias. Second, in 42% of cases, or 30 out of 71 measurements, discrepancies between devices would have resulted in discordant anticoagulation management decisions. Despite these measurement differences, no severe adverse events occurred during the author's study. And finally, that their study emphasizes the importance of device-specific reference ranges and calls for greater standardization in point-of-care ACT measurement. They suggest that future guideline recommendations should address these device-related discrepancies to ensure consistent and safe anticoagulation management during catheter ablation procedures. Next paper is also a brief report. The title is Cost Analysis of Antiarrhythmic Drug Monitoring in Patients Hospitalized with Atrial Fibrillation and Flutter by Dr. Abdul Minus and colleagues. The key findings for this paper include, first, that hospitalizations for atrial fibrillation or flutter and therapeutic drug monitoring, which may indicate oral antiarrhythmic initiation, are frequent in the United States. Second, that hospitalizations for AFib, flutter, and therapeutic drug monitoring cost $1 billion in the United States between 2016 and 2019. And finally, that future considerations for faster inpatient protocols or outpatient protocols for oral antiarrhythmic initiation in patients with AFib flutter are needed. The last two submissions are a letter to the editor and a response to the editor, and they refer to a paper that has, of course, previously been published describing iatrogenic complete heart block due to His bundle transection in His lead placement. Well, that ends the June 2025 podcast. Thank you for listening, and we'll be talking to you again next month.